Nice to, sorry, it's just started recording. Nice to meet everyone. My name is Justin. I'm with InnovAge. I am actually a co-partner to Leslie, who normally does some of these presentations. So I'm just stepping in for today. So I'm going to talk a little bit about who InnovAge is, what PACE is, if you guys are familiar with it. If you're not, I'm going to describe a little bit about the program, and then we'll go from there. So if you can go to the next slide. So what does PACE mean? So PACE is Program of All-Inclusive Care for the Elderly. For those in Pennsylvania, it's actually LIFE, and that's because there's a program called PACE in Pennsylvania, so Living Independently for the Elderly. So what do we do? Our whole goal and what we surround each other by is making sure that we're there to support individuals at home in that home environment, whatever that might look like, and to make sure that we're really helping them throughout the care of their life. Supporting them in whatever those needs are, making sure that they have a safe environment, and making sure that they're really getting that all-inclusive care. It's not just singled out as to one item. This is going to be our presentation for today. I'm going to talk about what the PACE model of care is, and then I'm going to go into, or excuse me, Dr. Ferrance is going to go into diabetes in older adults. So you can go to the next slide. So as I said, what is PACE? It's the program approved by the Centers for Medicare and Medicaid Services. So around the US, there are actually 272 PACE centers, and that's centers in 31 states. For InnovAge, we're actually in 5 states total. Obviously, we are definitely going to expand, but the entire PACE program serves over 55,000 older adults nationwide. That is huge when you look at, how many individuals can actually access PACE. What does that look like for them? And, where can we support them? Again, going over just the model itself, it is an all-inclusive model, and it's much more than that. A lot of people ask, are you just a provider? Are you just an insurer? What do you guys do? So I like to describe it as everyone is getting all the needs that they have necessary in their care plan. That's really, really important. And I'll go into talking a little bit about what that model kind of looks like in a second. But that's really important because when we're talking about the needs of people, we're talking about what they exactly are looking for every single day. There are individuals that are suffering that could get access to care that actually don't know that this is available to them. So it's important to look at PACE as not just an insurer, we're not just a provider. I like to look at us as a mix of both, and it makes things a lot quicker when you're accessing PACE, or what does that exactly look like. Also, it's not something of short. So what I like to say about that is a lot of people think that programs that they enroll into that might be 30 days, 60 days, 90 days. That is not the case. PACE is something that is long going, and that is why we call it a long-term care option. Next slide. So InnovAge, as I said, helps seniors live life independently at their home as long as possible. And our mission is to sustain and enhance the independence and quality of life on their terms for those we serve. Our goal, again, is to make sure that people are in communities, in their homes for as long and safe as possible. A lot of individuals you guys might encounter, and the way I like to really think about things is individuals really are not accessing everything they need to. So that is why a program like ours is there to help serve and help provide that support to them. And it's especially important when you're looking at individuals that might have, short-term disabilities or even long-term disabilities and things down the line for them or their family members. It's important that we talk about PACE because it's often not spoken about enough. Next slide. So how do you qualify for PACE? You definitely have to be 55 or older. So individuals have inquired that are 54 and they're getting ready to turn 55 in a month or two. So we can start speaking with them, but they can't actually enroll into the program until they're 55. They have to live within our zip code area. So that is especially important when we're talking about the zip codes that we service or the zip codes that we cover in every single state, because I know we're covering multiple states today. There are certain areas of coverage, as we like to call, that we are able to serve individuals. So that is determined upon their home or home environment. A lot of people always ask, does that mean that they have to have their own apartment? No, but that does qualify them. Some people might live, with family members, and that's their permanent residence. Some people might be in certain communities that's their permanent residence. Whatever that is, it has to just be within our service area, as we like to call it. They can remain safe in the community at all times. That is important. So individuals who are enrolling into our program, we have to make sure that they have a safe home environment. That does not mean that the individual, has a couple things going on that can't change, but really our goal is PACE. We're not there 24/7 in the home. So it's important to know that even when we're providing them the resources, that they're able to stay at that home environment. And then the fourth thing is the participant must meet the state skilled nursing facility level care requirements. So we look at those as ADLs or IADLs. So if we talk about ADLs, we're looking at their activities of daily living that you guys might encounter. So, is that individual dressing, bathing, how are they functioning in and out of the home? What does that exactly look like? Does the individual take care of themselves? Do they have somebody that supports them? And typically individuals that are in the hospital, going to skilled nursing, going to home care, they typically qualify for a lot of these programs, especially ours. So usually, we're able to pick that out right off the bat. And that's important for you guys to know. You don't have to qualify them, but you have to be aware, does Mr. Smith have falls? Does Mr. Smith, struggle with bathing or dressing? Who's helping him with his medication? Things like that are big indicators. So we always talk a lot to our participants or potential participants in that manner too, especially because when I say ADLs or IADLs, they probably have no idea what we're talking about. But when we talk about things like, hey, did you fall a lot, last week? Or, who was helping you get dressed? Who was helping you with bathing, toileting? And those are kind of indicators that we like to pull out. So that's why when you might hear people talk to participants or potential participants like that, that manner is especially important for us. Next slide. So this is our circle of one of our circles of care that we like to describe. And if you notice, the participant is smack dab in the middle. These are some of the services that we provide to them. Now, keep in mind, this is not all of them, but recreational activities. So within our centers, we have centers, again, placed in all those service areas. They're able to get that access to care. They're able to get, those meals. They're able to get that entertainment. What does that engagement look like? A lot of individuals might think that, PACE is just there to provide that approach of, we're here to just check in you on your appointment. We're here to just see how you're doing medically. But people don't realize that there's more to an individual, especially a senior, when we're talking about engagement. It keeps them active. It keeps them functioning. So that's important to us. We have our expert medical team. So obviously we have a medical director on the call right now, but it's not just the medical director, looking at that patient. We have a whole entire team that's making sure that individuals are being seen. Are they coming to the center? What services are they using? And a lot of people always ask about emergency care. So for PACE participants, they do not have to get approval to go to the ER. Now, we are looking at them all the time to make sure we're reducing those hospital readmissions or, hospital admissions in general, or them going to the ER. But a lot of people always ask, do they have to call the PACE center before they go to the ER? No. If they are having a medical emergency, we make sure that they go there. However, we are focused on that patient to make sure that that does not happen again. Transportation, to and from center or medical appointments. A lot of individuals say that, they're struggling or they're not receiving care because they don't know how to get to their appointments. This is especially important when we talk about access to transportation and what does that look like for us. For our participants, we ensure that they're getting to their appointments to and from. We're ensuring that they're going there on time. We're ensuring that we're focused on that whole patient. And the reason is because, again, we're trying to reduce those admissions to the hospital. We're trying to reduce those trips to the ER simply because somebody didn't go get, checked up, basically. Somebody couldn't make it to whatever specialist they were trying to see. So that's important to us. Dental, hearing, and vision. That's so important. So dental care is something inclusive of the PACE program. Now, this is not something that other programs will provide to them, but what individuals do not realize, or what participants do not realize, is that when you're talking about dental care, You're talking about what individuals need. You're talking about, just cavities, fillings, pain management, things like that. Sometimes infections, that can lead to other bigger issues that they might have. It's important that we're focused on that. Hearing and vision, we talk about, what we're providing to them. So if individuals are having issues and they need certain other medical equipment, such as glasses, for example, we're able to provide those. If they need to change their glasses prescription, we're looking at that, like what does that necessarily look like? Foot care as well. That's something that comes up all the time too. Does InnovAge provide podiatry? Is that something? So, we definitely have specialists within our network that we're looking at the individual, but not only that, our primary care docs are seeing things within our centers and notating things about the patient, notating, do they need, a certain type of care? So, we're not the only ones looking at the patient, but we're making sure that we're including all of that in that plan of care for them. And then as you can see below, tinctures, hearing aids, those are also important to the individual. Any medical equipment, any medical supplies, personal care at home, we're helping to provide that too as well. And this is why we talk about that all-inclusive care model. We're making sure that this person is safe at home. So if they need walkers, if we're looking at, canes for support, if they need wheelchairs, things like that, that we're like, what? This is really, really important to their health. And, they're not going to be able to make it past that or progress past that. And we're making sure we're providing them that support and care at home. And then we talk about prescriptions. We're providing medicine straight to the home. It's labeled morning, evening, noon, night, whatever time they're taking it, with a picture of the pill to make sure that these individuals are taking their meds. A lot of people, again, end up in the hospital simply because they weren't taking their medication, or they didn't know they had to take a certain medication. So it's important. Is there any questions on this before we go to the next slide? Okay, just want to make sure. So this is what we call our interdisciplinary team. And this is important because, as I said, it's not just only the physician or primary care provider. We're looking at, the nutritionist, what's important there. Home care, what's going on at home. Social services, making sure that that's there for them. Transportation, as I said before. Any other PTOT speech, we're making sure that the therapies are included, activities. So again, it's a whole team looking at this individual. And this is something that they're able to review. They're able to look at somebody prior to them coming on. They're able to review them annually, or however often that is needed for that patient. If there's any changes, then they're obviously reviewing that care plan too as well. But they're going in to make sure that this person is safe at home, that they have all the care that they need. So it is very, very important to think of that as, it's not just one person focused on the care, it's a whole team. Is there any questions on, the interdisciplinary team, what they can provide, anything that I can kind of answer on this slide? Okay, all right, next slide. And as I said, this is just a little bit more so you guys can kind of see the individuals that, again, are focused on that care. And again, we're looking at that care plan. We're talking about the staff, the providers in the network. What other services might this individual need? What does that look like? And this is important because a lot of individuals might say, hey, I have a community worker, or, I might have somebody just helping me out. But what services are we talking about? Because again, I'm talking about dental, I'm talking about therapies, I'm talking about, what does that home environment look like? Are they getting to and from their appointments? And this is all in one place. That is the biggest thing that I can say about this. And it's so important to talk about it from that angle, because they're not calling 10 different doctors. They're not calling different places trying to figure out what's going on. They can call us, our social worker, our care team. They're providing, some of those updates to the family. They're providing that resource. They don't have to call around to multiple places. And it makes it better because when you're talking about access of care, how quickly we're reducing all of those communication flaws where individuals might be in the community calling around and they didn't have information, and then one doctor did not know about, something else that was being provided to them. So it's really, really important that we're focused on that. Oh, sorry, got a question? Yes, that is coming up shortly from Francis Lee, it looks like. And then how can PACE help? Stabilizing the residents, hospitalization prevention, center visits, isolation, services under one roof, skilled nursing avoidance, case management, coordinating care, and helping the resident when they need higher level of care. And then next. And then enrollment. So enrollment for PACE can happen on the first of any month. They may disenroll at any time, and InnovAge helps with all paperwork. We help with financials. We help with anything that might qualify them, and that varies by state. So, you know, our information will be at the end of the slide, and we'll be able to help assist that. And then this is Dr. Ferrance. So were there any questions before we switch over to diabetes? All right, awesome. Thank you, Nina.
Thank you, Justin. Again, I'm Dr. Randy Ferrance. I'm the area medical director for all of Virginia for InnovAge. So we have 4 sites and Newport News, Richmond, Charlottesville, and in Roanoke. I'm the medical director over the 4 of them and oversee the primary care staff at those 4 centers. Just a bit about me. I've been a physician now for more years than I like to report in public. My wife and I were caregivers for her parents, both of whom unfortunately have passed away in the last year and a half at the age of 93. We looked after them for 28 years. So I'm well familiar with the role of the caregiver for the elderly, which is what we hope to have a partnership with families when we're dealing with PACE participants, because it's much easier to keep people safe in the home if there's someone in the home with them. And the best caregivers tend to be the sons and daughters, usually daughters. The sons are okay, but daughters are much better caregivers. I've also been a DJ since I was 16, and these pictures are actually from our PACE Center. These are the senior proms that we have done at our PACE Recreational Day Center here in Richmond, the 2 different years. One was just a 70s theme, and the other was a 1950s Hollywood theme, hence the reason I'm dressed a touch differently for those. But I really enjoyed, DJing in general, and it's really nice to see some of these people who walk around with a scowl on their face all the time get up and dance once in a while. So it shows a different side of our participants we've seen before. We will talk today about diabetes, and specifically we're talking about diabetes mellitus, because that's what everybody thinks of when we say diabetes, or if you're Wilford Brimley, you say diabetes. It's a problem with sugar. That's where the mellitus comes from. The other type of diabetes is usually diabetes insipidus, and we won't get into that because it's much more complicated and nobody really cares. So in general, diabetes is a problem with blood glucose. Generally that there is too much. And there are 2 main reasons this happens. One is the body doesn't have enough insulin to make the glucose do what it's supposed to do, which is to go from the blood, the extracellular fluid, into the intracellular fluid, which would be in the muscles and the other organs. So it hangs out in the bloodstream instead of going where it's needed. And then the levels rise in the bloodstream until bad things happen. The other reason we have high blood sugar is that we have insulin resistance. So some people have a lot of insulin, and in fact, most type 2 diabetics have too much insulin. To be perfectly honest, their circulating insulin levels are extremely high, but that insulin's not working very well because their body is resistant to it. So we have to counteract that in one way or another. These are stereotypes, but they hold pretty well in diabetes. Type 1 is typically diagnosed in children, in childhood. Occasionally, an adult will develop a diabetes type 1, usually through an autoimmune reaction of some kind. And just the way that works, we believe, at least, it's not 100% proven, but it will be infected with some sort of viral infection typically, and will form antibodies to that virus. And then the virus is all gone. These antibodies are hanging out, and they realize that there is a cell in the body that looks a little bit like the virus they were just killing. And in this case, it is the islet cells in the pancreas, which are the cells that make insulin. And so our own body, our own immune system, will then start attacking the islet cells in the pancreas and make it so that we don't make very much, or sometimes we don't make any insulin. That's a defect in making insulin. And this was, for a long time, until we discovered insulin, discovered how to harvest it initially from dogs, and then finally discovered how to make it on our own. It was a universally fatal disease. Type 2 diabetes typically manifests in teens and adults. And it is a product, again, of insulin resistance. We have plenty of insulin. In fact, we probably have more than we need, but our cells are not using it very well. There's a couple of reasons that can be. One of the biggest is obesity, because the extra weight just changes how we metabolize things and makes it so our insulin doesn't work quite as well. And if you have questions throughout this, feel free to type them in the chat, or even feel free to jump in here. I'm a better conversationalist than I am a lecturer, so I don't mind having a discussion as opposed to giving a lecture. Symptoms of diabetes in general, we speak in medicine of polyuria/polydipsia, and polyuria means, poly is many, P's, and many drinks. As the polyuria, polydipsia, so lots of thirst and lots of urination. And the reason for this is, if left to their own devices, our kidneys will keep our blood sugar about the 250 to 350 range, probably closer to the 350 range. The kidney will then just get rid of all the sugar by making us pee it away. But if it does that, it needs extra water in order to do that. And so it's going to make us thirsty. How would you know if you're insulin resistant or the other cause? We'll talk more about that in a couple of slides. And if I don't cover it well enough, we'll come back to it. Other things that happen include some increased fatigue because our metabolism doesn't work the way it should. Our body's not being very efficient, and so we tend to be more tired. Poor sleep can happen with this. Unintentional weight loss when sugars are very high, and sometimes they can be literally 1,000 to 1,100. Normal is about 90. So 1,000 is quite abnormal, 10 times the amount of glucose you're supposed to have circulating in your bloodstream. Your blood actually gets thick and you get a hyperviscosity syndrome, where you're not pumping well, you're not doing well, and people get very, very sick and very often get very, very confused as well. And then blurred vision. Typically, these symptoms are sort of the earlier symptoms. Unless it gets super bad, you don't progress on to the other ones. How do we test? We can do random blood glucose tests where we do little finger sticks and we can see where we are. We can send off plasma to the lab and find out where our blood glucose is. Hemoglobin A1C, probably most of, if not all of you, have heard of. This gives us an average of our blood sugar over the last 90 days. The reason it's 90 days is our red blood cells live about 90 to 120 days. If the more sugar that is floating around in your bloodstream, the more sugar will get into these cells. So this is a test where we take red blood cells, we chew them up, we find out how much sugar is in it by a percentage. Normal is less than 7%. And then anything over that tells us the blood sugar has been higher than what we consider to be normal or average. And there's a long, complicated math formula on how to determine what your average blood sugar was based upon what your hemoglobin A1C was. And when I want to do that conversion, I get a piece of paper and a pencil and I put them aside and Google the calculator because it's really complicated. We used to do oral glucose tolerance tests a lot. Those aren't done very much anymore because we have better set diagnostic criteria for what is diabetes and what is not. And those change so frequently, I hesitate even to mention them here, quite honestly, because they may well be changed by the time you all get home. We do finger stick testing pretty frequently, and now, fortunately, we have continuous glucose monitors, or CGMs, we call them. There are two main manufacturers of those. One is a little round Freestyle Libre dot that it gets attached and stays on for 14 days. The other is the Dexcom. It looks a little more oblong. It is only good for 10 days at a time, and it will send your blood sugar on a near continuous basis. The Dexcom actually samples every 5 minutes and sends it to a smart device, either its own acceptor, its own reader, or to your smartphone. The Freestyle Libre, I think now they have it so that it will automatically synchronize. It used to be that you had to tell it to synchronize whenever you wanted that done. It would store 8 hours worth of data. They've become extremely handy for us to use, especially in our older participants. Very often when we check their blood sugar, they're high, but we know that they've had low spots in between. And we'll talk a bit more about it as we go on. But in the elderly, we're far more worried about low blood sugar than we are about high blood sugar. So how do we manage type 1 diabetes? The bottom line is they're not making insulin, or they're not making nearly enough. We need to give them insulin. And then the other side to that is carbohydrate control. It's not so much not eating carbs, it's eating a steady, consistent number of carbs at all the time. And again, most of the people who are diagnosed with type 1 diabetes are diagnosed when they're children or they're teenagers. And so we kind of get in early with the dietary management and help them with this. Type 1 is a bit frustrating sometimes because it can be what we call brittle, where a tiny bit of insulin will go a long way, and sometimes adjusting their insulin regimen be quite difficult. We don't see a lot of that in our population. To be honest with you, 30 years ago, we saw almost no older adults with type 1 diabetes because very few of them survived into older adulthood because they didn't have great ways of controlling it, and so they would suffer all the complications of diabetes, and they would not live as well. Just how 30 years ago, children with cystic fibrosis rarely became adults, but now it's fairly common for a number of different reasons. Managing type 2 diabetes, the most important thing here is going to be the carbohydrate control. The fewer simple sugars they take in, the better off they're going to do. Exercise for a couple of reasons. One, because exercise helps to drive that glucose into the muscle and into the other organs to help us metabolize it. It does the job of insulin, essentially, which is not working well. So by exercise, we increase how well it works. Also, that can lead to some weight loss, and every 10% of weight loss makes a significant difference in how well we can control diabetes. And then, of course, we have medications. We can give insulin, but as I said before, most of these folks already have plenty. So what we prefer to give them are medications that help their insulin to work better, work harder. A few that work on the transport of insulin from the bloodstream into the cells, which is part of the problem. Some other ones that help to regulate insulin a little bit better. Some pills actually make us make more insulin, but we try and concentrate more on the medications that help insulin to do its job better. And then there's also medications that help us get rid of sugar. Most people are familiar with diuretics. Those are water pills to make us pee. We give them particularly to folks with some congestive heart failure or weak hearts so that we can decrease their blood volume so their heart's not having to push so much, or if they have high blood pressure. Those tend to work by making the kidney get rid of salt. And then water follows the salt in the kidney without going into a long physiology lesson that none of us want to get into. Water follows salt, but water will also follow sugar. So we can change that kidney threshold. Instead of it being 300 to 350, we can make the kidney get rid of sugar at 150 to 200. So it is a diuretic. It's going to make them pee more often than they would otherwise, which older adults are not necessarily very fond of, but it does help to lower sugar very well and also helps to protect the kidneys from the effects of diabetes. Complications of diabetes are many. They are varied. They come from a number of different sources, but most of the problem is the fact that the body was designed by our creator to have a certain glucose level. And if our glucose level is significantly higher than that for a significant period of time, our cells are bathed in sugar more than they should be, and they glycosylate, which is a fancy word for take up sugar. And sugar, once it's in a cell, it's got to do something. And what it usually does is deposit itself or cause the body to have some sort of reaction to it, which then harms the cell. It makes us far more likely to form plaque on the inside of our arteries. So hardening of the arteries as we get older, which is what leads to things like stroke. If it's an artery in the brain, or a heart attack, if it's an artery in the heart, people with diabetes tend to have a much worse rate of atherosclerotic heart and cerebral vascular disease. Does the same thing for the arteries and the rest of the body. So our legs in particular seem to take the brunt of that, where we have more and more trouble getting blood flow through to the different organs. It also works on small arteries and even the capillaries, such that we'll get normally we can kind of count on blood flow going perfectly to our fingertips and our toe tips. But with diabetes, after a long period of time, especially if it's poorly controlled, very little blood flow will get through to the toes and to the fingertips. And so the toes will get dusky for a time, and then they can actually begin to form gangrene because they're not getting blood flow. They become ischemic, fancy word for no oxygen, and they die, quite frankly. Neuropathy, high levels of sugar bathing the nerves will damage the nerves. This typically manifests by a burning, tingling sensation in the hands and the feet, particularly the feet, and a decrease in sensation. And this is why, every time I have a person with diabetes in my clinic, the nurses know I want their shoes and socks off to remind me to check their feet for how well they feel. And also because they can stub their toe and cause an injury and sometimes not feel it, strangely enough. Erectile dysfunction, this happens the same way everything above happened. We clog off the blood supply to the penis, and we can also cause neurological problems. So it can be either a vascular or a neurological erectile dysfunction. Either one's got the same end result. And then wounds, just as we talked about the tip of the toe not getting enough blood flow and therefore becoming gangrenous, the same thing can happen to a layer of skin. That we don't get very good blood flow to the outer layers of the skin, and it just begins to form a wound. These can be devastatingly difficult to treat. We see them a lot on the feet of people with long-term, especially uncontrolled diabetics. In general, if people control their diabetes very well, these are less likely to happen, but there's never a zero chance. If you have diabetes, there's always a chance you're going to form a wound, even if you've done everything perfectly. More likely than the average population, I guess I should say. Diabetes signs of trouble. Low blood sugar can lead to things like confusion and sweating. This is the body's normal reaction, is to have kind of a stress reaction. So sometimes there's tremors, and what the body is trying to do is stress your body enough to make it release cortisol, to make, the rest of the body is trying to get one organ, the adrenal glands, to release some cortisol, because when your cortisol levels go up, your sugar level will go up as well. They can be very tired, lethargic, just not thinking clearly, feeling hungry. Very often, as the blood sugar starts to head down, people will note that they feel ravenous, and that is their body's way of telling them to get some glucose into them. They can also get irritable and anxious and moody, and they can actually lose consciousness. Now, high blood sugar hurts us over time. All those things I've talked about the last couple of slides, like your heart disease and your wounds and your erectile dysfunction, kidney disease, those take years of bathing the cells in too much sugar. So yes, high blood sugar over 10, 15, 20 years can kill you by making you have a heart attack or a significant stroke or a wound that leads to an infection that'll take your life. But dropping your blood sugar into the 20s when it should be 90 to 110 and leaving it there for a significant period of time can kill you today. So in the elderly in particular, we physicians worry far more about low blood sugars than we do about high blood sugars. And as a result, for the typical population, the 40-year-olds, where goal hemoglobin A1C is less than 7%, once you reach 70, we say, well, we're okay with 8%. And once you reach 80, we're okay with 9%, because at 80 or 90, chances are they're not going to be around long enough for all those really bad things to happen 20 years down the road. But again, they can die tonight if their blood sugar drops too low, if we control them too tightly. Symptoms of high blood sugar, usually that increased thirst and the dry mouth that we kind of talked about. In type 1 diabetics in particular, they'll get a fruity odor to their breath, because what's happening is, although there's lots of sugar in their bloodstream, way too much sugar in their bloodstream, it's not getting across the blood-brain barrier to feed the cells of the brain. The brain needs energy or it shuts down. The brain will protect itself at the expense of the rest of the body. So it starts to form ketones. The best way to do that is to break protein down and break muscle down. Doesn't have to break down a lot of muscle to form enough ketones to make the brain happy. But those ketones then start circulating and they'll give us a fruity odor. These people, it's often mistaken for alcohol, especially if someone's having a diabetic emergency and they're in a car accident. They will smell like a drunk driver. And unfortunately, sometimes that delays them getting the care they desperately need at the time. Confusion can happen when the blood sugar is particularly high, blurred vision. And the reason the blurred vision occurs is because there's extra sugar around there. It's going to draw extra water into the eye, which actually changes out changes the shape of the eye and changes where the light is supposed to focus on the retina, and it makes their vision blurred. And then, of course, tiredness. Maybe blood tests. Not sure I understand the question. We do blood tests to figure out where we are on the scale when people are presenting, and you know, we at the scene of an accident, unfortunately, you can't do a blood test to tell if somebody is drunk versus has diabetes, but usually they have portable breathalyzers these days. So they'll give the breathalyzer to someone who is having a diabetic emergency, and it reads that it's not alcohol. And that's typically how they realize they've got something else to worry about. Just a quick discussion of the PACE model. We work differently than typical primary care in that we do a lot more shared decision making. It used to be in the old days of medicine, the physician told the patient what we were going to do, and that's what they did. And, you know, back during the days of therapeutic nihilism, the turn of the 19th into the 20th centuries, where we had legitimately, we had 2 different medications that did any good. And the rest probably did more harm than good. Being paternalistic was probably about the best thing because folks, by their nature, unfortunately, there's a lot of folks who like to take medications, and so would probably take medications to their own detriment. These days, medicine has shifted significantly, but particularly in PACE, we use the phrase all the time, we meet patients where they are. So if I have someone in their 80s who says, you know, I just don't care if I control my diabetes or not anymore, I understand that that means that I could develop wounds and my legs could rot and fall off and I'll go blind and I'll have a heart attack. I'm okay with all that. If they're going to be okay with that, I will do my best to be okay with that, but I will meet them where they're at. They don't want to take medicines. We'll trim their list as far as we possibly can trim it, so that they can take as few medicines as possible. And of course, it's always their right to say, I'm not going to take any medicines. Obviously, you know, I'm talking about people who still can make their own decisions. And in elderly patients who can't make their own decisions, we have this conversation with family and involve the patient, but, you know, the final decision ends up with someone who's able to comprehend risks and benefits and make decisions like that. So it really should be a give and take. It should. I ask participants all the time, what is your goal for yourself for the next 6 months? And the first couple of times I do that, they look at me so confused because no one's ever asked them that before. You know, and sometimes I got to explore with them to find out what their goal is. And you know, to me, a goal is not, well, to live as long as I can. A goal is to be able to dance at my granddaughter's wedding next month. Yeah, or to be able to see, you know, see my my grandchild graduate from high school or from college. Those are goals. My father-in-law, when we discovered that he had colon cancer, his goal, this was in February, his goal was to see my daughter graduate medical school in May. And we weren't sure that was going to happen, so we rigged a graduation. It might have involved a touch of subterfuge, but that's how I get to tell everybody now that I was a keynote speaker at a medical school graduation once, because I gave the keynote address at my daughter's graduation. I do my very best to try and meet the folks where they are and give them what it is they want to get what they want out of life. Because, you know, when I'm 80 or 90, if I want a piece of chocolate cake once in a while, I really don't want somebody telling me no at that point. And if I say I want chocolate cake for all 3 meals, I'm hoping somebody tells me no. But, you know, there's got to be a bit of moderation to it. But I think that there's a lot of give and take, and we can give on some of what are normally our medical goals. As far as how we can tell if we're insulin resistant or the other cause, typically, you know, by presentation, because a type 1 diabetic who's not making insulin, when they first discover that they have diabetes, they're going to be really sick because their sugar will be very high. They will be ketotic. They will be in a lot of trouble. The type 2 diabetics tend to come into their illness more slowly. So it's months worth of history of increased urination and increased thirst. And then the blood tests will tell us when this is our suspicion and we're doing a blood test to check on the hemoglobin A1C and check on their random blood glucose level. That is, and we'll typically run a test for the pancreatic cell antibodies And also very often we'll run an insulin test, see how much insulin is circulating in the body. And we also do a test for something called C-peptide. When our body makes insulin, it has a little thing on the end of it called a C-peptide, which makes it not work until another enzyme comes along, cleaves that C-peptide and turns it into regular insulin. So if someone's got an extremely high blood insulin level, but they have a very low C-peptide level, there's shenanigans going on, whether the person is injecting themselves with insulin, which we occasionally see, or someone is injecting it with insulin, sort of a Munchausen syndrome or a Munchausen's by proxy, giving them trouble. So we tend to run all those tests just to see where things are and get an idea of how significant the problem is up front. And I've probably rattled on way too long on this stuff. So, just how we define success in PACE is if participants are happy and they're as well cared for as they possibly can. That's what we're looking for. I thank you all for your attention, and I'm happy to entertain any other questions you might have.
So Dr. Ferrance, I know one of the people that I'm not sure if they're on the call because I don't remember who asked me the question, but they were wanting to know about maybe getting this presentation at their property for their residents. I know you're obviously in Virginia, but I'm assuming that there's people similar to yourself in the states that our participants are from. Is that an option for them? And if so, what does that look like?
You mean to have someone actually come on site and give a talk?
Yes, or if virtual is the only option at this point, I guess, is that an option as well?
I think many physicians are happy to do this sort of thing. And we're all kind of busy. Just like all of you are all awfully busy. The last couple of years has really changed how we work and taken a lot of people out of the workforce. And so those who are left tend to be working much harder than they should. And probably most of you work for a company much like mine, where if you do your job really well, you get the opportunity to do someone else's job really well too. But I think if you are cooperating or working with medical professionals, I think a lot of them are happy to teach. Most of them really enjoy teaching, and it doesn't have to be a physician. It could be a nurse practitioner, a PA. It could be a nurse. Nurses are very well versed in how we handle diabetes as well.
Perfect, thank you. And so would they coordinate that through Leslie, or I guess who at InnovAge would they reach out to?
Yeah, I think Leslie is the contact person for trying to make that sort of thing happen.
Okay.
That's probably the best person for that. And Francis Lee, to your question, elaborate more on insulin resistance and how one would know they're insulin resistant versus the other cause. It's really going to take laboratory tests for us to tell. That's the bottom line. We can get a 95% likelihood by history. If someone, typically if they are type 1, if they have type 1 diabetes, then they will, because they're metabolically not working properly, they tend to lose weight just before their diagnosis. Whereas most people with type 2 diabetes will tend to gain weight because they're creating more and more insulin, and insulin itself is lipogenic, which is the fancy word for saying more insulin makes you gain more fat. One of the reasons we try now to put people on medications other than insulin, because we know that if we give them insulin and then we tell them to lose weight, we're almost making it impossible for them to do so. Not impossible, but difficult.
Dr. Ferrance, if that's the case, then why do some type 2 diabetes people take insulin?
Because sometimes we just cannot help them to use their insulin well enough, and we have to cover by giving them additional insulin. But we don't yet have the medications that will make the insulin work well enough that we don't necessarily need more.
Okay, but if they're insulin resistant and we're giving them more insulin, wouldn't that kind of defeat the purpose?
Typically, we manage to, we managed to be able to overcome a little bit of that. And so if we have a participant in whom we're having to give more insulin and more insulin and more insulin and more insulin, yeah, then we get into a vicious cycle sometimes. But for a lot of people with type 2 diabetics, we can get by with 10, 15, 20 units of long-acting insulin a day, which is not that much. That's, not a whole lot more than we need to give to people with type 1 diabetes. So it's kind of like physiologically replacing. They just need a little bit more than what they're currently making. I've certainly seen patients that were giving 1, 2, sometimes 300 units of insulin a day. And in those folks, we are definitely creating a problem because there is no way they're ever going to be able to lose weight when we give that much supplemental insulin. We would prefer not to, but sometimes we just don't have any other choice.
So Dr. Ferrance, sorry, I have one more question. If that's the case, wouldn't people take insulin be better than taking medication, since insulin, from what I understand, does not have side effect because our body has it anyway, versus medication that are manufactured that can have that can come with side effect?
Well, it depends. If they can tolerate the medication, it helps them to leverage their own insulin better. And most people do tolerate those very well. And sometimes with those medications, we don't have to put them on additional insulin. Then that tends to be better. The best thing is to get them to be careful with their diet, to lose some weight. And a lot of people with type 2 diabetes can, resolve their diabetes, at least temporarily, by losing weight and being careful what they eat. A lot of people claim a lot of different diets. I see the question about vegan diets. Vegan diets will tend to help because there's fewer carbohydrates in that, and a good vegan diet that focuses mostly on protein. But sometimes a keto diet that's not vegan will also decrease how much medication we have to give people with diabetes, and occasionally even, temporarily, at least, make it so they don't need medication at all.
Thank you.
Surely.
Are there any other questions, either by unmuting or through the chat, that anybody would like to ask? All right, I will take that as a no. Thank you, Dr. Ferrance and Justin, for your time today. We appreciate it. And thank you to all of our members for taking the time to join us and for asking wonderful questions. As I mentioned earlier, this recording will be available on our YouTube channel. So if you do have coworkers that wanted to join but were unable to, please feel free to point them to that. Just give us a couple of days to get it up there. But thank you so much. Have a wonderful day.
Thank you all.
Thank you.